Should be good.
Yes, perfect. Well, happy February. We got through Groundhog's Day. I can't tell you what the groundhog said because I'm just, hunkered down and trying to. I say that I live in Georgia. Jill laughs at me. I don't have the snow you guys have. I try to avoid it at all costs. But somehow every year in December or January, I end up in Michigan. And what this December was no different for our company Christmas party because our home base is in Fremont. What I want to do for you today is not give you a how-to on cost reporting. I want to give you the whys and the what it means, if you will. So some of this is going to look familiar because it's cost reports. They haven't changed. And then some of it will look a little bit different. First of all, I want to let you know what does it do for you. And if anyone has seen me before, I've got a trusty Mickey Mouse coffee mug. I am going to talk with my hands. It is who I am. It is what I do. I prefer in person. So I'm going to pretend like you are sitting right in front of me. And I'm trying to teach you the methodology behind how you get paid as a rural health clinic. Because the cost report is like your tax return. At the end of it, it's who owes who. It reconciles what you've been paid all year long. They've been paying you claim by claim. At the end of it, we submit this cost report. And after everything we're going to talk about today, costs, visits, vaccines, bad debt, they look at what they've already paid you on a claim by claim basis or an interim lump sum basis and figure out who owes who. So it's where it reconciles. It also is going to determine what they're going to pay you claim by claim next year. And it's where you get paid for these pass-through costs of pneumococcal influenza, COVID vaccines, and your Medicare bad debt. So it's where the rubber meets the road, where we really figure out who owes who, where they set your interim claim by claim basis payment, and where you get paid for pass-throughs. You're going to hear me say this. If you've heard me, this is if you leave this session not understanding that your RHC rate is cost divided by visits, then I'm thinking you might have checked out right now, because I'm going to say it once, I'm going to say it 10 times through this. When you are looking at a rural health clinic model, you are looking at cost divided by visits equals my RHC rate. RHC cost divided by RHC visits equals my RHC rate. And that distinction becomes important. Well, is that what I get? All right, let's find out what bucket you fit into first. If you are an independent or a newer provider-based, here's your caps. And I want to really drive that home because I've had a lot of confusion this year with people not understanding that this is not a PPS rate. This is a ceiling. This is a cap. It is cost divided by visits equals my rate subject to this ceiling. Okay, if you're independent, we're in 2024, your cap is 139. That does not mean you're going to be paid 139. That's the ceiling. If you're provider based, less than 50 beds, I think I deleted the wrong one. That should be less than 50 beds. And you came into the program prior to 12/31/20, then you have your own cap. So everybody else has these published caps. Your cap is you have to look at your 2020 cost report, M3, what is your cost per visit? That is your baseline cap, and it goes up by the Medicare Economic Index, the MEI, each year. So you either have a federal cap or your own individual cap if you are a grandfathered provider-based, less than 50 bed hospital that was enrolled or applied to enroll before 12/31/20, you have your own specific that starts in 2020 and is indexed forward. So I want to stop here and just talk about, for those of you who've been around for a long time, and I've noticed some familiar names here. Hi, Keisha. Hi. We know some people that we work with on a day-to-day basis, and they understand this. Every year we were talking about what is my cost per visit and just making sure it was above the cap. I mean, it is what it is. But we looked at and we focused at, as a maximization technique, making the cap every year. I don't think the independents are going to make 190. We're not the government. We can't spend what we don't make. I think you're going to fall right about where your highest payer pays you. Our new focus, whether you are independent or whether you're provider based, is going to be finding that sweet spot. If you were a less than 50 bed hospital and you didn't have a cap before, now all of a sudden your CFO is looking at you saying, okay, we need to talk about your cost. We need to talk about, and you don't, I actually have had that call. What, why? And the reason is we need to find your target. It's about optimization right now. We need to find where your cost per visit sits and then watch to be sure that it doesn't go up or down, because remember, at the end of the day, we're going to file this cost report and we're going to find out who owes who. And if on an interim basis they have been paying you too much, you could owe them back. Too little, they may owe you. We need to find that sweet spot. And so when we talk about this calculation again, cost divided by visits equals our rate. And we know that the cost report sets the interim rate for future periods. It's where we are made whole for a prior period. If we don't know what our target is, if we don't even know how to calculate this, we are going to, you could have a surprise, and we don't want a surprise at the end of the year. The focus points for you now are your costs. If your costs go way up or way down, if your visits,
What else?
I'm sorry, if your visits go way up, way down, that can skew your rate and it can cause surprises at the end of the year. Okay, so we're going to focus on cost. We're going to focus on visits. If any of those have major swings, whether providers leave or come, maybe you get an influx from closed practice, there are other ways that all of a sudden your visits are way up, your visits are way down, your cost is way up, your cost is way down. You really need to talk to someone who does your cost report, who is a financial person that understands this, and find out if you're going to make your target. And you do need to know what your target is. Okay, so if we're looking at cost and we're looking at visits, let's just talk about those components and what those mean to you. Here it is, the inverted triangle. Anyone who's heard me speak before has seen it. It comes in various colors depending on the time of the year. We're in the dead middle of winter, so we got a nice deep blue here today, but it doesn't change. We have healthcare costs, we have overhead costs, and we have non-RHC costs. And I put them in an inverted triangle so you understand the importance and where we want most of those costs to be, which is in that healthcare cost section. And why is that? Because that middle section, that overhead section, is going to allocate itself on this cost report based upon the ratio of healthcare costs to non-RHC costs.
I didn't pop it.
So what goes in each section? All right, let's talk about the top of that triangle. That is just what it sounds like. It's healthcare costs. These are patient care, direct patient care costs, cost to deliver the patient care, compensation for your healthcare staff, compensation for your medical director, physician supervision, medical supplies, malpractice, license, CME, make sure that they go up in that healthcare cost. There's a line for that. professional dues and subscriptions that directly relate to your healthcare providers, your flu, pneumo, and now COVID vaccines. Transportation, you got to be careful with that one because it is only for personnel if they're going from one location to the other related to patient care. One healthcare institution to another healthcare institution. So we've got the triangle, top of the triangles, healthcare cost, including what you would think are indirect costs, but the CME and the professional dues and subscriptions related to your healthcare staff. The middle, the overhead that's going to allocate itself, what goes there? Well, we have two types, facility, administrative. Facility is just what it sounds like. It's your building. The rent, the insurance on it, the interest on it, the utilities on it, the other building expenses, building, facility, overhead, and administrative overhead. Your admin staff, your legal and accounting, your telephone, your IT costs. Your EHR goes down here. Other administrative costs, office supplies. Because remember, and this is the best way I could figure out to tell you, inverted triangles, little arrows, the overhead section, that facility overhead, that administrative overhead, it's going to, the cost report, it's a very simple calculation. It's within the forms of the cost report. You don't do it, it happens behind the scenes. It's going to allocate itself based upon the amount you put in the healthcare versus the non-RHC block. All right, Julie, what in the world is non-RHC? I get this question. If we were live, someone would be asking this. Wait a minute, I am in an RHC. Everything I do in my clinic is RHC. I don't understand. Okay, well, let's talk about that. When we talk about non-RHC things, we are talking about things that are paid outside of your AIR, outside of your all-inclusive rural health clinic rate. It's not that it's illegal. It's not that it's a bad thing. It's just paid differently. It's not paid as part of your rural health clinic all-inclusive rate. We call it non-RHC because that's actually how it's labeled on the cost report, non-RHC. So when we think of non-RHC, think of not paid as RHC, not paid as part of the rate. Top 5 things: the technical component of lab, X-ray, EKG, CCM, and telehealth. Those are the top 5. There are other things. I know we've got intensive outpatient management. We've got some remote patient monitoring coming into the arena. I don't see a lot of that. I don't have any of our clinics that have that. But if you have anything that is paid over and above the rate, outside of the rate, we're talking about on the Medicare side. I know Michigan has a list that they pay in and out. That's not what we're talking about. We're talking about doing the Medicare cost report. Because honestly, the Michigan is not really a cost report. It's a reconciliation of claims. We can get into that later, JAMPS and all of its loveliness. If it's paid outside of the rate, it goes in the non-RHC center. But we're only going to leave it down in the bottom of that triangle if it needs to grab some overhead, because overhead's going to allocate itself based upon what you leave down there versus what you have in your healthcare cost. It becomes important when we start talking. So let's just kind of run through some examples, because that concept alone can just blow people's minds. Lab, X-ray, EKG, that's a simple one. It's going to grab overhead. So we have to reclassify the direct cost because it's done in your building. We're talking about the 6 required lab tests that are done in your building. We're talking about X-rays that are done in your RHC. We're talking about EKGs that are done in your RHC. They had the technical component should be billed to Part B by independents. It should be billed through your hospital as a hospital outpatient service for your provider-based RHCs. And by the way, I'm here if anyone has, okay, I must just do a little quick jot to the side. I've seen on Facebook pages, on private emails and some stuff where there was a Medicare contractor that disallowed some vaccines because they saw outpatient lab, x-ray, and EKG claims on the same day. And it's supposed to be that way. So if you get any MAC that's telling you, hey, you can't have a service in your RHC on the same day you have a lab, x-ray, EKG in your outpatient hospital setting, they don't understand. And I'm here to help. Let me know. Be glad to get involved and train and get these folks to understand that this is by design. You are going to have outpatient lab, x-ray, EKG claims in a provider-based RHC setting on the same day you have RHC services. It is because of the technical component billing instructions.
Julie, quick note before you move on. Just a
Yep.
question in the chat for you.
Yeah,
And it reads, so any newly established RHCs would be considered independent regardless of hospital bed size? Correct? Question mark.
okay. No, not technically considered, but capped as an independent. The caps apply to new provider-based, but there are still some benefits to being provider-based. Overhead allocations from your hospital. That's the biggest one that I could think of as to why you would want to stay. It doesn't have the benefit it used to, but it doesn't mean you're not provider-based.
Sure.
But you are capped the same as an independent, correct, if you come in now. I also believe that Michigan still differentiates. And so your rate with Michigan Medicaid is going to be different, and I believe higher if you are provider-based. I hope that's helpful.
Yes, we got an affirmation for that. Thank you.
Okay. All right. Circling back in here, we've got cost divided by visits equals our rate. Anything that is paid outside of the rate, over and above the rate, we're going to have to carve it out. We're going to put it in the non-RHC cost center if it captures overhead. We're going to pull it off the report altogether if it doesn't need to capture overhead. These three things, we want them to catch some overhead. So we actually have to pull the direct cost down. What I want you to understand here is that when you or somebody is asking you to capture costs for this, first of all, less is better. Don't double count yourself. In my mind, there's really, I mean, there's probably more ways, but there's two top ways to get it done. You either time the staff or you time the test. So you time the people or you time the test. For most of our new folks, they don't keep dedicated time studies. So we actually time the test, but you don't want them to time the whole processing of it because they may be moved on to the next patient while that one's processing and you're going to double count. It is human nature to overstate the amount of work you do to your boss. So as you're doing time studies, let the folks know that less is better and that we just really want hands-on time here. Because what we're trying to do is take direct cost of providing this service down into the bottom of the triangle, down into that non-RHC cost center, because it's going to catch some overhead. But unless you have detailed time studies, the average time per test is the best way to get this done. Just something, little side note here. Remember, venipunctures are paid as part of your rate. Don't carve those out. You're getting paid as part of your rate for venipuncture. Don't carve those out. There we go. A little slow on my computer. There we go. Okay, we've talked about lab, we talked about EKG, we've talked about X-ray. Those are the top three. Technical component gets billed to Part B. It is supposed to get billed to Part B through your hospital, or if you're independent to Part B. We're going to pull the direct cost down. The overhead's going to allocate itself. Remember, don't calculate an overhead component. The cost report will do that for you. The other two are chronic care management and telehealth. CCM. First of all, you got to figure out how you're doing it. Are your folks doing it? Or are you hiring a company that is sending you a bill for this service? Why is that important? Because remember, if we leave it in the bottom of the triangle, if we leave it in that non-RHC cost center, it's going to grab some overhead. We only want it to grab overhead if it's our people that are doing it, that are using our lights, our water, our break room, our employee benefits, our IT stuff, our phones, all of that. So if it's done, that's the orange here. If it's done by the clinical staff, we're going to reclassify the direct cost down into a non-RHC cost center. I think the common way to do that is based upon the billable. You've got those 20-minute codes. Let's just take 20 minutes for it, or you can keep some time studies. The 20 minutes is just a common surrogate that we use. If it's handled by an outside company, they send you a bill, you're going to just take that bill, exclude it, and you're going to exclude the incremental billing cost, maybe just a portion of your biller that does these CCM bills. You don't want to throw it down in that non-reimbursable cost center, all that money that you pay to the CCM company, or it's going to grab overhead too. They don't work in your building. They don't use your lights, your water. You don't want that call center to take a portion of your lights and your water. Okay, we're back. Right now we're talking about carve outs. It's cost divided by visits, RHC cost divided by RHC visits equals our rate. Right now we're talking about the things that are paid outside of the rate. Because they're paid outside of the rate, you don't count the cost. We're talking about how to carve it out. And you also don't count those as a visit either. Telehealth, and that's where it becomes important. That's where that visit piece becomes important. And also the distinction between what type of telehealth you're doing. Remember, the mental health telehealth is now billed as a visit, just the same as it's paid at your AIR. If it's paid at your all-inclusive rate, your AIR, the cost stays in, the visit gets counted, it gets paid at your rate. The physical telehealth, because it is paid outside of the rate, differently than the rate, separately than the rate, we have to pull those direct costs down, let the cost report pull some overhead down, because it is paid on its own fee schedule. How do we do that? All right, how do I pull this down? What I found when I was trying to just back in those months when this was brand new, we were all locked down in COVID, I found that folks generally fell into one of three camps. They either had all the data, complete time data. I have one Arkansas clinic that I am telling you they are on it. They can tell you every minute. Some of them, they have some of their providers that are keeping time data, some are not. And remember, when we're talking about time data, do not be careful not to just pull the amount of time that record is open, because you could be overstating it if they left it open and went and saw another patient and then came back and closed the record. I've seen that as a possible road bump for these calculations. Or you kept no time data. Just remember the goal. What we're trying to do is find out, the ultimate goal is to reclassify direct cost. To do that, you find out how much provider time you have in telehealth, and then you're going to multiply that by their wage and go down. You also need to know the time, because we're going to pull it out of the FTE counts. If you didn't keep any time records, I think a good useful surrogate would be if you can pull the CPT codes for those telehealths. They have time associated with the definition of each CPT code. You could use that. We have on some clinics where they fall into this last bucket with the no time data. We'll pull a report that has CPT codes on it, and the 20-minute, the 30-minute visits, the 45-minute visits, we can use that as a surrogate. So we've calculated the cost that is not paid at the rate, and we are making either reclassifications if they capture overhead, exclusions if they don't use our overhead. One other thing I want to mention in this, getting your cost down, cost divided by visits equals our rate. RHC cost divided by RHC visits equals our RHC rate. Our related party transactions, these are very separate concepts when we talk about independent versus provider base, as far as how they commonly show themselves. Commonly in an independent world, related party has more to do with the owner of the clinic also owns the clinic building, but sets up a holding company, and there's tax benefits for that. Medicare is going to make you eliminate the profit factor here. They're not going to pay the profit factor. So that you zero out the rent and you add back the actual cost of ownership. Usually you can do that pulling it off of a tax return, Schedule E, or if it's set up as its own S Corp, you could pull it off of an S Corp tax return, but it's actual cost of ownership. Have to eliminate the profit factor. Now, in a hospital setting, we more often see it as hospital overhead allocating itself to this clinic. It is important that if you are over this cost report, or the folks that actually do these cost reports, pay attention to the statistics. There's actually a worksheet within your hospital cost report that has statistics that are used to allocate cost to the rural health clinic. If you don't use the cafeteria, then you shouldn't have a cafeteria statistic. But if their director of nursing oversees your nursing staff, then you need some of the nursing overhead. Do they service your snow removal and your housekeeping? Well, then you need a piece of the property plant management and their and I've lost it, the snow people, wherever they are, you need a little bit of theirs. Again, I'm in Georgia. We don't have snow down here, and if we do, we completely shut down. It's a whole other story. There's an SNL skit even about it. Buford, I don't know. We shut down. The other thing I see in a hospital setting, even more so, and it kind of goes back to that question that was just asked. Hey, if we're new, are we not hospital-based anymore? You don't have to be. I see a lot of hospitals that will have an arm of their entity, a physician's practice management arm, and really they'll have their clinics up under that. That could be a related party issue that you need to disclose. And the management services that those folks provide to you, first of all, make sure you're getting a piece of it. Did a clinic, we actually just did some 831 reports that we're doing at the end of January, and had a hospital district that we were working with. And I'm like, where's your time talking to the accountant, talking to, where's the malpractice insurance? Well, the hospital district pays that for them. Well, let's get it allocated over here, either by direct allocations or statistical allocations if you're part of their hospital. But when you have parent companies that provide services for you, don't just leave it over there. Make sure you do get a cut of it, but also check those statistics where they're allocating costs to you to be sure that you are getting your proper allocation. Okay. So let's go back to our concept here. It's cost divided by visits equals our rate. We've carved out the things that are paid outside of the rate, over and above the rate. The vaccines, the influenza, the pneumonia, the COVID and monoclonal antibodies, I don't think anybody's giving those anymore, but they're still on our cost report. That's where you calculate what Medicare owes you for those. So we report these as a pass-through cost on here. So when we talk about cost divided by visits, it's actually net of vaccine costs. So how does that happen? First of all, in case anyone is just buried in the snow and has not been paying attention, Medicare Advantage COVID-19 and monoclonal antibody products back in 2020 and 2021, they were paid through this cost report. Beginning in 2022, that you have to bill those to the Medicare Advantage plans. I hope, we're 2 years later, I hope everybody is on board with that. I just wanted to throw that out there in case someone was late to the party on that and still not getting their proper Medicare Advantage claims out for COVID-19 vaccines. All right, so how it's passed through, I get a lot of questions. What are we getting paid? And are we covering our cost? Absolutely. You're not just covering your cost, you're covering a little piece of overhead too. First of all, let's talk about how to get paid. What do I need to do? Got some 3 columns for you. Make sure you include your invoices. Make sure you include your Medicare logs, and this is traditional Medicare only. Don't include VFC. It skews this calculation and how this works. And we have run that through some contractors over time. They agree if you put the VFC in there, it skews the cost per visit. We're going to go over how that's calculated, and hopefully that'll make sense to you. Keep, don't necessarily send in your logs to support total vaccines given. You have to be able to support the influenza, pneumococcal, and COVID vaccines you gave to everybody to get paid for what you did for the Medicare. So how's that? And okay, one more thing you got to keep up with. So we're talking about invoices, Medicare logs, send those in, total logs, just keep those, have them, but keep them. You also have to do a vaccine time ratio. When you do this vaccine time ratio, the biggest mistake I see is not including physicians' time in the ratio. Wait a minute, Julie, they don't give vaccines. Why am I including that? You have to include their time in the total time because of how this calculation works. And if you don't, it's going to skew the calculation. That's the easiest way to tell you. I could explain the more detailed version of it. But basically, when you are doing this vaccine time ratio, it is vaccine time to total time, and total time are all healthcare staff. When we, well, come on, computer. There we go. When we're doing the vaccine time ratio, because it's vaccine time to total time, vaccine time to total clinical time. What we have seen in the industry, you can do some time studies if you want to need to bring this down, but we have had, and I do have something from at least one of the MACs in writing that says they accept the 10 minutes as just the industry standard, the industry practice for these vaccines. Take your number that you gave to everybody, multiply it by 10 minutes. That becomes your vaccine time. For the COVID vaccines, we recommended time studies. There were just so many folks in there. Remember, don't include the time that they're waiting, that mandatory waiting period if you have one, because you're off doing something else. We don't want to double count on these shots. So we take the total vaccine time, vaccines times 10 minutes, and divide it by total healthcare hours. And the reason we do that is this ratio gets multiplied by total healthcare cost. That's a more complicated topic. I am happy to walk anybody through it. These are the questions I get. What do I get paid? How do I get paid? I don't understand. Am I really getting the $250 it's costing me to buy this high dose, whether it's high dose flu or the Prevnar? Those are high costs. They want to be sure that the owners of your clinic, the administrators at your hospital, they want to know if they're going to buy this stuff, that they're going to get paid for it. Yes, it's aggregated, but yes, because you not only get the direct cost. So let's look at that first column. The direct staff cost, that's computed using those numbers I just gave you. It's a little more of an advanced topic. You also get direct supply costs. Pull them off your invoices, put them in their respective cost centers. Don't forget to send your invoices in. Makes your audit life a whole lot easier. Sometimes they won't even contact you. They already have it. Then you actually get an overhead component too. So you're not only going to get the cost that you spent on the vials of vaccine, you're going to get an overhead component too. I've gone into the details here. I'm not going to bore you with that now. For the bean counters like myself of the group, there's how to do it. There's all of the equations to get it done. But basically, they take direct cost, a calculated overhead piece, divide it by the total number of injections you gave to get a cost per injection by type, by influenza, by pneumococcal, by COVID. What does it cost you to give these injections to your patients? And then they multiply that by the number of their patients, the traditional Medicare patients, and they pay you that amount. So it's direct plus overhead divided by the total you gave everybody to come up with a cost per injection. Remember, that includes direct staff time, direct supply costs, which you paid for the vials, plus an overhead. Cost per injection, and then they multiply it by the number of traditional Medicare by vaccine type that you gave, and then they pay that to you. That's how you get paid for the vaccines. So we have cost divided by visits equals our rate. We talked about cost. It's all, we want as much up in that healthcare cost. Overhead allocates itself. Non-RHC are the things that get paid outside of the rate. We know you do them in your clinic, but they're the things that get paid outside of your rate. We make a quick stop at vaccines, so you get paid, they calculate a cost per injection by injection type and multiply it by the number of their patients, by the traditional Medicare patients. Don't forget your logs, don't forget your invoices. Cost bubble is complete. We have a bow on it. We know what the RHC cost is at this point. Visits. What is an RHC visit? Okay, nice, beautiful colors on a February day. Face-to-face encounter. You have to be able to break it down by provider type. If it doesn't get paid at your AIR, you don't include it here. You don't include hospital, you don't include non-covered services, injections only, blood pressure check only, lab only. If it doesn't get paid by your AIR, you don't put it in here. You don't include medical telehealth, but you do include mental telehealth, because the mental health care telehealth gets paid at your visit. If it gets paid as your AIR, it gets counted as a visit for this equation. They're by type of clinician. All clinicians working on a, so let me just stop here. Cost divided by visits equals your rate. Visits is going to be the greater of your actual visits or your minimum visits by the productivity standard. 4,200 per physician, 2,100 for your APPs. It's by FTT, it's in aggregate. We'll go over that calculation here in a second. Locums, you don't put locums in for the minimum, but that visit is not a static number. It is the greater of your actual or your minimum. What is a mental health? I threw this in here because I've been getting this question not just once, not just 2 or 3 times, but talking about, hey, these telehealth visits I have, they're at least half, if not the majority of them, have mental health diagnosis. Isn't that a mental health telehealth? Don't I get my visit? No. The mental health telehealth that are paid at the AIR, effective, again, we're at 2 years now. I'm hoping everybody's on this bandwagon at this point. They get paid at the 9827, has to be one of those 900 revenue codes. It is not a physical, normal telehealth for anxiety, depression done by a provider. These are the 9,000 codes. I know that, or 90,000 codes. I know that at a national level, they're working on this, or it is a topic of discussion to have that addressed. Right now, this is where we sit. So when I talk about a mental health telehealth visit, I'm talking about these codes, not a telehealth visit that covered a mental health diagnosis. That's considered a physical telehealth, paid outside of the rate. We're going to do the carve out, paid differently. We're talking about Medicare here.
Julie, another quick question or question/comment in the chat is, Does anyone plan to discuss today the benefit of adding specialty services, specialty practice services, example, ortho, cardiology, etc., within an RHC? Second part of the question, if these specialty services make up less than 50% of the total RHC visits, are these reimbursed at the all-inclusive rate?
Okay, it's not an if. If they're done in your RHC, you're billing them as an RHC visit, which you should be, then they're going to get paid at your AIR. And whether you should or shouldn't is really a kind of a basic math problem, in that what does your AIR look like in relation to how you would have gotten paid had you done it at a different location. Sometimes it's really about the service to your patients, and there are some that this is a patient care decision more than a financial one. It is not an if they make less than 51. It is if they are more than 51, you can't be an RHC. It's more of a compliance issue. And I think there's some math that needs to be done before those, and it's clinic specific, but they need to be done before those services are offered in the rural health clinic. Is that helpful? All right. So this, and I'm about out of time. I got just a few more minutes. These are just some examples of mental health billing. I am not a biller. I'm just throwing these up as examples from people who do know billing, and that told me this is how it gets done. What I do want you to know about on the visit counts. Well, let me grab myself again, pull myself together back again. Billing examples. I also wanted to mention that you are going to have this breakdown. This is required. This is an informational only breakdown of the visits, just in case you want to know what kind of information you have to keep up with. Okay, cost divided by visits. Remember, visits is the greater of actual visits or the minimum. The minimum is calculated based upon FTEs times the minimum. How many physician FTEs you have times 4,200. How many APPs you have multiplied by 2,100. It is aggregated and then compared to your actual visits, and you get the greater of. They're going to charge you with the minimum, whether performed or not. Again, we're at 4,200 physician, 2,100 APP. Locums are not subject to your productivity standard. Remember, that is not contracted physicians that are there all the time and are paid on a 1099. It is not based upon 1099 versus W-2. It is based upon, are they regulars or are they just filling in for somebody on vacation? It's applied in aggregate. Talked about the fact that it's compared to the total. And, you know, I always love to say, if you've got a productive employee, they can make up that deficit. I think it's important that we know that this is everybody's in one pool at the end of it, and that the total minimum is compared to your total, and you get the greater of, and it's all part of the equation. Because I have folks that will ask, what's the penalty? It's not that it's a penalty, no penalty. It's just there's a different number in the equation, cost divided by visits. You are trying to figure out what that number is, and it can affect how you get paid in the end. Couple of tips, especially if you're bumping up against that minimum, make sure if you've got a physician, the amount of time they're doing preceptor duties, medical director duties, maybe they're doing true administrative duties, inpatient duties, because inpatient visits don't get paid at the RHC rate. Don't count them as a visit. Don't count them in the FTE hours. Make sure you carve out that cost. If it's paid outside of the rate differently than the rate, inpatient visits are like that. They are not paid RHC. So we need to be sure we reduce that physician's FTE for those. Don't forget, when you're capturing your total hours, that you have to capture the physician total hours, the APP total hours, as well as your clinical support staff total hours that go into that vaccine calculation. If it's paid outside of the rate, don't count the visit, don't count the time, and make sure that you pull that cost out as well. If you can't make the productivity standard, there are exceptions available during COVID. Everybody got one. If you asked for one, you got one. Before COVID, and we're headed right back there now, it's going to be harder. You actually have to have a really good reason. You're in a remote ski village and you have seasonal. You're out on the middle of an island in Lake Michigan and you have seasonal. Maybe you don't make your FTE, your minimum FTE, because of the seasonality of your population. That would be a reason. There can be reasons then you actually have to apply to your MAC. And if you Google that with them, if it's WPS or if it's Palmetto requesting an exemption to the productivity standard, there's actually forms to fill out to do this. How do I know how my FTEs are? This is purely just a tool that we designed. You don't have to use it. It's a very simple one. It can help you. You could have your folks do it at least 1 week a month, not the same week every month, to figure out what a normal work week looks like for them, to figure out what the FTEs are. Again, this is just a tool. All right, cost divided by visits. We know that's subject to a productivity standard. If they're doing services that are not paid at the rate, we're going to bump their FTE down a little bit by that. Cost divided by visits equals our rate. Okay, so then we know that is the general way that we get paid. We have a pass-through for flu, pneumo, COVID, monoclonal antibody. We have a pass-through also for Medicare bad debt. Very quickly, what it is, Medicare bad debt are unpaid traditional Medicare deductibles and coinsurance. If they're Medicaid, cross it over, write it off. If they're not Medicaid, and you haven't had another way to determine indigence, that's a high bar, by the way, go through collection efforts, then write it off. Put it on this log. Make sure that you have their Medicare number, that the log is very specific and it is patient by patient. Couple of tips here. Make sure you send that first bill timely. We've seen some exclusions where the first bill didn't go out for a year and Medicare just says, you know what, it's not our fault you didn't bill for that. And they just blanketly disallowed that. The latest audit we had that did those blanket exclusions said that the first bill had to be sent within 120 days. Then there has to be at least 120 days from the first statement date to the date of write-off, unless you have now if it's Medicaid, cross it over, write it off. That 120 days does not apply. Send your first bill within 120 days, collect for another 120 days before you write it off. Be consistent with the collection policy that you use for all other provider types. That's the easiest way to tell you. First of all, it's traditional Medicare. If you can't tie it back to a paid traditional Medicare claim, deductibles and coinsurance, it does not go on this log. If they're Medicaid, cross it over, get your Medicaid payment, put it on the log. If they're not Medicaid, bill them, send that first bill timely, and bill for at least 120 days consistent with how you bill everyone else. Just a couple minutes left. I threw some other information on here. I'm not going to go over it. This is just, I think it's just good information for those that, hey, I don't do any of this. It's great to know it, but I'm just gathering information to do my cost report right now. So, hey, here's a list. Things you need to have. Salaries by employee, CCM, but just a nice little list. And Jill has this slide deck of the things that you need to do your cost report. Nice little list of other information that your cost report preparers are going to need. Be sure you know who's going to electronically sign your cost report. Just a quick tip. Last but not least, are you enrolled in any demonstration projects? Do you have a relationship with an ACO, specifically when that ACO flips to a DCE? That is an advanced topic that only applies to a section of this population. So I don't want to go into it, only to say, a lot of you guys have ACO relationships and they'll slide you that contract every year. Be sure you're reading and paying attention at the point that that ACO flips to a DCE, where they receive your Medicare payments and they pay you on a capitation basis. It changes how this model, it changes, that becomes your interim payment on this cost report. And with that, we are right at the 2 o'clock hour. Jill, you have any more questions?
We do. We have one more question in the chat for you, and it is, are the specialists billed as a specialist or family practice provider?
Billed as an RHC patient, there's no, there's not a distinction. That provider has to be enrolled as an RHC provider, but there's not a different rate for specialists. Your rate is, it's cost divided by visits equals your rate. Whether it's, no matter who in your RHC has done that, it is going to be paid at your RHC rate. There's not a specialist RHC rate versus a primary care RHC rate. The RHC rate is the RHC rate.
Awesome. Thank you, Julie. Does anybody else have questions for Julie? We'll certainly take the next couple of minutes. If you want to come off mute and you're comfortable, feel free to come off mute and ask a question. Otherwise, again, you can put it in the chat. And
Yeah, I'm here. Just any questions.